I welcome you guys to my YouTube channel, The Medic Man. Today we are going to see about the long bone of the upper limb, that is the humerus. I've divided this part into three videos. First video is about the upper end of the humerus, second would be of shaft, and third would be of the lower end. So, humerus is the longest bone in the upper limb. We already know it. It is also known as hammer bone because it resembles the shape of the hammer. Next, for determination or for learning of the humerus, we first have to learn about what is the side determination, okay, and how to hold the humerus in the anatomical position. Okay, first of all, while looking towards the head, the upper end is rounded and forms the head. The upper end is directed medially, upward and backward. So if we are holding the humerus, like we have to see that the head of the humerus is directed medially, that is the head, it is pointed towards our trunk. Then the lower end is flattened. Okay, if we have to determine the humerus, we have to see the upper end and the lower end. For the lower end, we have to see that the capitulum and the trochlear is present anteriorly, while the olecranon fossa, it is present posteriorly. So by next, the upper end already we have seen that the upper end is directed medially, it is directed upwardly and backwardly. The upper end articulates with the glenoid cavity of the scapula, and thus it forms the glenohumeral joint or the shoulder joint. The upper end, there is a presence of three imaginary line, which we called as neck of the humerus. So there are total three neck: the anatomical neck, the surgical neck, and the morphological neck. The anatomical neck separates the head of the humerus from rest of the upper part. Okay, it is separating the head of the humerus and rest of the upper part, while the surgical neck separates the upper end of the humerus from the shaft. So the surgical neck forms the boundary between the shaft and the upper end of the humerus. Then there is a morphological neck. Morphological neck, it is present between the anatomical neck and surgical neck. One more distinguishing feature is that the surgical neck is the most common site for the fracture to occur. If there is a trauma or the deep impact on the humerus, then there would be a chance that the surgical neck may rupture, and this may cause fracture of the humerus. Now, seeing the tuberosity, okay, the upper end has presence of some impressions which we call as tuberosity. Okay, there is presence of greater tubercle or the greater tuberosity, the lesser tubercle or the lesser tuberosity. The greater tubercle, if we are holding the humerus in an anatomical position, the greater tubercle is present laterally, while the lesser tubercle is present medially or the anteriorly. The lesser tubercle has three impression: the upper end, the medial part, and the lower end. While the lesser tubercle is clearly seen in the anterior surface, there is a presence of elevation on the anterior surface of the upper end of the humerus medially, and this is known as lesser tubercle. And between this tubercle, there is a presence of intertubercular sulcus. Okay, between these two tubercles, there is a presence of intertubercular sulcus. This intertubercular sulcus has two boundaries, and these two boundaries are known as lips of the intertubercular sulcus. Laterally presents the lateral lip, and the medially presents the medial lip. Further, what are the attachments of the upper end? Okay, so we can clearly see that, or we know that the upper end of the humerus there is no origin of certain specific muscles, but there is insertion of the muscles present. So, anteriorly seen, there is a presence of insertion of supraspinatus, subscapularis, pectoralis major, latissimus dorsis, teres major, while posteriorly there is insertion of infraspinatus and teres major. So, first of all, saying about the supraspinatus. The supraspinatus originates where it gets originate. It originates from the medial two-third of the supraspinatus fossa of scapula, and it's inserted. Where is get inserted? It get inserted into the uppermost expression or the impression of the greater tubercle. Where it get inserted at the uppermost impression of the greater tubercle. Then there is subscapularis. Subscapularis originates from the subscapular fossa of the scapula, and this subscapularis get inserted. Where it get inserted into the lesser tubercle. Greater tubercle supraspinatus, lesser tubercle subscapularis. Then is the presence of subpectoralis major. Pectoralis major generally originates from the costal cartilage or the ribs 1 to 6th, between 1 to 6 ribs and the costal cartilage and the anterior surface of the sternum, and pectoralis major get inserted on the lateral limb of the intertubercular sulcus. We have seen that intertubercular sulcus has two limbs, the lateral limb and the middle limb, and on the lateral limb the pectoralis major get insert. Then there is a presence of latissimus dorsi. Latissimus dorsi originates in three parts: the vertebral part, the costal part, and the scapular part. The vertebral part originate from 7 to 12th thoracic vertebrae and thoracolumbar fascia, while the costal part originates from 9 to 12th rib and scapular part from the inferior angle of scapula. And this latissimus dorsi get inserted into floor of intertubercular sulcus. Okay. Then there is presence of teres major. The teres major originates from posterior surface and inferior angle of the scapula, and it get inserted on the medial lip of the intertubercular sulcus. And posteriorly seen, there is infraspinatus and teres minor. The infraspinatus originates from medial two-third of infraspinatus fossa, and infraspinatus get inserted into the medial impression of the greater tubercle. Upper impression supraspinatus, medial impression infraspinatus. Then there is teres minor. The teres minor get originate from posterior surface of scapula and the lateral border of the scapula, and teres minor get inserted to the lower part of the greater tubercle or the lower impression of the greater tubercle. So these were the insertion of muscles on the upper end of the scapula, the upper end of the humerus. Further, we are going to see the blood supply of the upper end of humerus. So the axillary arteries which is coming towards the humerus get divided into posterior humeral circumflex artery and anterior humeral circumflex artery. It forms a ring-like structure around the neck. Then there is arcuate artery which travel along the medial lip of intertubercular sulcus. Lastly, it receives from the vessels from the rotator cuff. These were the major blood supply of the head of the humerus. Next, the nerve supply and the vein drainage. The nerve supply. The upper end receives the nerve supply from the axillary nerve, and the arteries drains into anterior and posterior circumflex humeral vein, and this circumflex humeral finally gets drained into the axillary vein. Next, the clinical view. The clinical view of the upper end, what is the there is chances of fracture, or there is a chances of avascular necrosis. Avascular necrosis is the ischemic injury to the epiphyseal bone leading to the collapse of the head and arthritis, which can seen in the feature or the picture, that is, in the first picture there is a normal head which is receiving healthy supply of the vessels, while the second is of case of avian, there is a collapse of the head of the humerus and there is a decreased blood supply, and due to this there is pain and cracking during the movement of the joint. So this was about a vascular necrosis. Then comes the fracture. We have already seen that is the upper part. The most common area for the fracture is the surgical neck. While seen on whole of the humerus, the most common sites are the surgical neck, the shaft, and the supracondylar region. Okay, when there is force applied in one direction on the humerus and the joint capsule and the rotator cuff muscle remains intact, that means that there is no movement of the joint capsule and rotator cuff muscles. A fracture in this area is most likely cause the damage of the axillary nerve and also the posterior circumflex humeral artery, which may hamper the movement of the humeral humerogleno joint or the glenohumeral joint or the shoulder joint. Thank you for watching and hope you will have learned many things, and do subscribe my channel, the Medic Med.